Paul put me in a difficult position in terms of the scheduling, both in terms of following Richard and his family story, but also trying to connect some of the themes over the last couple of days. And what I thought I would do, just to start with my disclosures, and there's one on here for Paul in particular. So if you notice, in addition to my roles with ASN in the Council of Medical Specialty Societies, the American Society of Microbiology, I'm an investor in a restaurant that's near his house, so I'm hoping that he will become a regular and help pay back my investment. For those of you who don't know, the American Society of Nephrology has been evolving over the last 15 years or so, and it's become, we were calling it the ASN Enterprise, but nephrologists love Star Trek so much that they got distracted. So we started with the terminology, the Alliance for Kidney Health, which we sort of like. And so the way to think of it is it's ASN, which is the Medical Specialty Society, which is like other medical specialty societies. It's the ASN Foundation for Kidney Research, which funds our grants programs. It's the Kidney Health Initiative, and you heard a lot about that today, particularly from Carolyn and from Eliza. The Nephrologist Transforming Dialysis Safety, which is our partnership with the CDC to eliminate preventable infections in dialysis facilities. And finally, Kidney X, which had come up a couple of times today as well, which is our partnership with the Department of Health and Human Services, which is intended to accelerate innovation in the kidney arena and try to accomplish much of what Richard and others have been talking about. I'll circle back to these, but that's the way to think of it from sort of an organizational perspective. And as a sort of alliance, if you will, at a staff level, and when we're working with our physician volunteers and our other health professional volunteers, we've developed this mantra. And yesterday, Rachel Meyer, who's our Director of Policy Government Affairs, really deserves credit, because this is a conversation that she and I have been having for a long time, which is when an issue comes up, so should ASN support X? The mantra is, well, what's best for people with kidney diseases and their families? And we say people with kidney diseases, we try not to say patients. What's best for these individuals? And then if what we're looking at is best, then we say, okay, well, what would this also be best for strengthening the relationship between these individuals and their caregivers, if they're nephrologists, if they're nurses, if they're other health professionals? Okay, if that's still going in a positive direction, then what's best for the specialty of nephrology? What's best for the broader community? And then what's best for our collection of organizations as it aligns to the vision, missions, and goals? And if all those align in that order and we're supportive, we're in the right. And it's the right decision to make. We can defend it, and usually we can get momentum behind it, both within our organization but also across the community. And invariably, it's going to align then with resources, and it's going to align then with our margin as a not-for-profit organization. And I just wanted to start with that as I transition into this quote. And so this presentation's organized around what's called the Stockdale paradox. And for those of you who don't know, U.S. Commander James Bond Stockdale was the highest-ranking prisoner of war from the United States during the conflict in Vietnam. And he spent 7 years in the Hanoi Hilton, the infamous prison. And after the war, he was asked how he survived that experience. And he said, "You must never confuse faith that you will prevail in the end with the discipline to confront the most brutal facts of your current reality." And so if I leave here with one thing, it's that you remember the Stockdale paradox, because I think that's where we are at this moment in time in nephrology. And as a starting point for that, let's just go through, and I'm going to do this as fast as I can, because it is brutal, and just talk about what the brutal facts are in nephrology at this moment in time. And those of you who have kidney diseases, those of you who have kidney failure, those of you who have been transplanted, those of you who work in the field, either as a nephrologist or as a health professional, if you work for industry, I think all of these facts will be familiar to you. And it happens just by coincidence, there are 9 of them. I'm not clever enough to then try to align them with each of the circles of Dante's Inferno, but I'm sure someone in here who can. I see Jim Sloan already challenged to this. So just as you go through these are brutal facts, but I think we need to start here, be honest with ourselves, and say at this moment in time, this is what we're dealing with as a specialty. Kidney diseases lack appropriate recognition, respect, and sense of urgency. A number of people have said that yesterday and today. Roberto talked about the number in terms of the total burden of the disease globally. You're familiar with it here in the United States. I'll come back to that in a second, what the cost to this healthcare system is. Given all of that, why isn't this better known? Why doesn't the National Football League dedicate a month to people with kidney diseases, just as an example? Or the National Basketball Association, which has had several transplanted players. Number two, the cost to the healthcare system, this is in the United States, of treating kidney failure is unsustainable. It's unsustainable when you think about the Medicare program as an entitlement and you look at the federal budget. There's no way we can sustain what we're spending at this moment in time. It's something that we're going to come to a head in the near future. The federal government underfunds kidney research. And one way to look at that is just to randomly select a few diseases: HIV, AIDS, cancer, heart disease, kidney diseases. And then, okay, what's the prevalence? And unfortunately, we're the only community that can't agree on the number as to how many people have kidney diseases. And that's unacceptable. Every other disease can do it. And I recognize it may be easier in others, but we have an obligation to say, this is our best number for the United States. We've done it globally. Here's our best number. So for fun, I just listed out all the different ones I could think of that are publicly available. These are all citable. And then I just ran the numbers. Okay, this is what the appropriation is for each of these diseases across NIH. And then let's just divide those. And you can see how much we spend per patient. And that's unacceptable. Regardless if it's 20 million Americans or it's 40 million Americans, the final number is unacceptable as a number. And then you compare it to the other diseases, it gets worse. And I'm only up to number 3. Number 4, oh, now it freezes, right? I had that dramatic moment. Just before I get to number 4, I just want to pick on the Alzheimer's Association for a second. No one challenges this number that 22 million people, that $22 million is spent by taxpayers every hour on Alzheimer's. Does anyone actually believe that? What we argue about is it 20 million, 26 million, 31 million, 40 million. The Alzheimer's community puts this out, and then you look at what the appropriation, the concomitant appropriation is for NIH. That's the world we live in, and that's what we need to just first confront as a brutal fact, then come back with a plan as to how we're going to address that, because that's our responsibility. As Joe Muldoon told you yesterday, venture capital has little interest in kidney diseases. If you look at this slide, it's a whole set of diseases, cardiovascular, neurological, all the way down to dermatology and the venture capital investments. And you can tell what's missing from here is kidney diseases, despite the fact that 850 million people worldwide have kidney diseases. So, not surprisingly, we've had less innovation. There's less federal funding for kidney disease, there's less venture capital, private support, so there's been less innovation. So just quickly looking at the approvals, and just comparing us to the total number of 99 over 3 years, for cancer 29, for kidney diseases 4. Again, unacceptable. This has come up several times, just to put it as bluntly as possible. Dialysis, a federal program that pays through a bundle and is dominated by a duopoly, defines nephrology. Number 7, nephrologists are underpaid compared to other specialists and their value to the system. So if you look at physician compensation, and you can see nephrology is sort of in the bottom third, at the top of the bottom third, but sort of in the bottom third. But then you look at recent data as to where their value in the system is, it turns out that the systems, that sort of what they're producing for the systems, nephrologists, is more valuable than gastroenterology, cardiology, pulmonology, urology, most internal medicine specialties. However, their pay scale is lower. Why is that, and how do we address that? As many of you know, nephrology has been struggling to fill its fellowship positions, and so if you kind of go through this chart over the last decade, you can see that there's been a big gap between the number of fellowship positions and the number that have filled through the match. Interestingly, and this is just a side point, we've increased during that time where we've had a harder and harder time filling fellowship positions and attracting the next generation of nephrologists, we've increased the number of positions by 26%. So what makes sense at a local level does not make sense at a federal level, at a national level. So it's a huge challenge that we have to deal with. And I'll come back to that in the next section. And then finally, I think it's important for us just to acknowledge that at this moment in time, healthcare professionals, including nephrologists, face at least 9 existential threats. And those threats have to do with their professional ecosystem and how that's changing, their professional expectations and how those are changing, but also just a level of personal anxiety that we've never had to deal with before. So those are the brutal facts. There's probably others that some of you would like to include. I'll be the first to admit that some of these we could argue and we may have different perspectives on, but I think we have to acknowledge that at this moment in time, there's a lot of challenges to nephrology as a specialty. So the second half of the Stockdale paradox is that we must maintain faith that you will prevail in the end. And I think there's a lot of encouraging things, particularly in the United States in this moment in time, that we should start to focus on and we should start to highlight more. So the first would be, let's focus on improving kidney care and kidney health. And there's sort of 3 elements to that. So first is that the lexicon in nephrology as a specialty is not helpful. CKD is a meaningless term. ESRD is a meaningless term. ESKD is a change to a meaningless term. Let's talk about what we mean. Let's give people hope by having honest conversations about their disease. And let's communicate to the public at large about what we're talking about. KDIGO next month is holding a conference where they're going to start looking at some of these issues and try to address some of these lexicological challenges. The second part is I think we need to move from being lumpers to being a little more clear as to the different elements of kidney diseases. We're not talking about CKD, we're talking about kidney diseases and the relationship, if you want to say cardiorenal, diabetic kidney diseases and all the progress that we're starting to make in that arena, genetic kidney diseases and the story that we just heard and how many levels there are there, acute kidney injury from Roberto's presentation earlier and some of the challenges and opportunities there, dialysis and Bruce's presentation from earlier about home therapies and PD and everything that can happen there. Transplantation, so I didn't want to ask Peggy this question directly, but it bothers me when we separate sort of the transplant community from the rest of our community. It's one unified community. Let's have that conversation and end this turf battle. And then finally, end of life and having serious discussions around end of life. If we framed nephrology in these types of terms, and we could add onconephrology, there's a lot of other opportunities, I think it becomes both a more attractive specialty, but it also becomes a lot more understandable from a public perspective, and I think it changes our discussion to more positive. One way ASN is starting to think about this is by targeting programs specifically to these areas. So I already mentioned that we have this relationship with the CDC, where we're looking at preventable infections in dialysis facilities. It's really becoming a broader discussion around how can we improve dialysis care. I show also the new logo where we've actually dropped nephrologists, so it's just transforming dialysis safety, I think encompassing that broader vision. We're in the process of launching an emergency partnership initiative where we will be helping improve care for disaster relief in the United States and the Caribbean. Because that's an area where there is some coverage in the United States. I think we'd all agree that the Caribbean needs more attention, and there are a lot of people either on dialysis or who suffer acute kidney injury in disaster situations, and we have an obligation as a community to care for them. So that's another piece that also relates. We just recently received funding from Baxter to launch a new program called AKI Now, which will be focusing on promoting excellence in the prevention and treatment of AKI. And as I mentioned earlier, there's a lot happening in diabetic kidney disease, and I think we have an obligation to figure out what the role of the nephrologist is and how the nephrologist will interact both with primary care, but also with subspecialties like cardiology and endocrinology. So the second reason to have faith is that the federal government is interested in kidney diseases for the first time since 1972. And that's both from a regulatory perspective, which is this one, and this quote's already been used, but just to read it, I think Bruce had it, just to say it again. One of the key reasons for our failing policies is that kidney care in particular has some of the worst incentives in American healthcare. That's the Secretary of HHS. You can't have a bigger advocate in government making that kind of statement. I was on a call recently, Rachel and I were on a call recently with a high-ranking government person at HHS, and he said, I've never seen this much cooperation on one issue. The buy-in across HHS is absolutely wild. Kidney diseases are like cancer and Alzheimer's now. Finally, we've broken through. We've got their attention. Let's take advantage of it. And as a result of some of this interest and attention, the HHS is about to unveil what they're calling a kidney strategy. Think of it as our moonshot. And the Deputy Secretary for HHS, Eric Hargan, has been very clear as to what the elements are going to be, and they're all things that have been discussed over the last 2 days. One is we need more efforts to prevent, detect, and slow the progression of kidney disease. So there's 2 pieces there. There's a huge investment in thinking about creative ways to fund research, innovation, and discovery, but also thinking about innovative care models and how you slow the progression of disease. The second piece of it would be we also need to provide patients with kidney failure more options for treatment, both today's technologies and those in the future. So again, there's a link there to research, discovery, and innovation, but also this idea of alternatives to dialysis, which then gets to in-center dialysis, home dialysis, et cetera. And then it gets to the third one. We need to deliver more organs for transplants and develop wearable and implantable artificial kidneys. Again, research, innovation, and discovery, but also thinking about ways that we can move from increase the likelihood of transplantation, and Peggy outlined what that agenda is. And as she didn't mention this, but one of the things is that the administration is going to come out in favor of the immunosuppressive drug coverage bill. It's going to be huge. So we're making progress there. But the third is that we also have to convince the legislative branch. So how can we work with Congress, which everyone knows is split currently, to get them excited? So nearly a third of Congress, either formally, so I'm talking the House and both the House Representatives and the Senate, about a third, either formally through this letter that's shown here from the House or from individual communications in the Senate, supported Kidney X, said we think that this idea of an appropriation, which has not been authorized, but an appropriation for Kidney X is meaningful. We would like the government to spend money. Now, while Ryan, who's sitting right there, was working on this and wanted $25 million, and his performance evaluation will reflect this, we only got $10 million. The reality is $10 million was in the House Appropriations Bill for Kidney X. That is a big step. We have many steps to go. It is a complicated process, but what's important is we had a bipartisan, bicameral approach to supporting Kidney X and therefore kidney diseases. And I've already summarized that in the executive branch, we have support for doing this kidney moonshot. So things are starting to come together at the highest levels of our government, which could be meaningful for generations to come. Holly Owens from Amgen could spend the rest of today on this one slide. So if people want to stay after, she's happy to do it. I think what's important here is there's a lot of levers as you look at reimbursement, and those levers are both government levers and private sector levers. Those levers are both in enhancing innovation, but also looking at traditional models of payment. And if you were to ask where we as an organization spend a lot of our time, it's navigating through this and trying to pull each of those levers, influence those. And we're not alone. Organizations like the Renal Physicians Association, other members of our community, AAKP, other patient organizations, we're all working together on these. And I think we may have slight differences, as Peggy said about DIPTA, and I think I was actually the one who coined DIPTA, but whatever. Because its predecessor was ICA, which I liked even better. The point is that we mostly work together and we try to work across as broad a coalition as possible. So a fifth reason for you to be excited about the future. Nephrologists are reimbursed for telehealth. They can care for patients in their own homes. We were the first specialty to secure this opportunity, and it started this year. And other specialties are looking at us and saying, you're the model. Think about that, how powerful that is if you're trying to recruit the next generation. Think about how powerful that is if you're in, my wife's family is originally from Durant, Oklahoma. If you're in Durant, Oklahoma. I mean, there's real opportunities to think about this and to think about how we can improve care, but also raise the profile of nephrology in ways that we haven't been in the past. 6, foster innovation in new therapies and product development. I'm trying to, on this slide, connect both Rob Starr's presentation to Carolyn and Eliza's to the discussions around Kidney X. And the point's simply that you have the National Institutes of Health, which spends about $600 million a year on kidney research, and they have really innovative, creative, and I think transformative programs like CureGN and KPMP, which Rob Starr described earlier today. You then have organizations like ASN, the ASN Foundation for Kidney Research, funding individual investigators as well. And there's a fair amount of symmetry between those two efforts, although obviously there could be more, and I think that's an opportunity. And they're really trying to develop both the preclinical information, but also the next generation of researchers. Then you have the Kidney Health Initiative, and in this example, just thinking about one project around surrogate endpoints for clinical trials in FSGS and IgA nephropathy, you have trying to eliminate the barriers and working with FDA. And I think I don't want anyone to leave this meeting without realizing how hard FDA is working to work with us to really address these barriers and overcome some of these challenges. And then you have KidneyX, which is trying to increase sort of interest in the outside world funding these innovations and bringing them to market. And so again, in this one specific example of sort of genetic kidney diseases, there's currently more than 16 trials looking at different genetic diseases in kidney diseases. And if some of these are successful, we will have therapies, and hopefully through KidneyX and other mechanisms, we will be able to bring these therapies to market. And by one, it's sort of hard to read right here, but by one news account, the market for FSGS alone by 2025 is $16 billion. And at the end of the day, that's what's going to drive both innovation but also investment, is if investors see that kind of money in this arena, they will start coming to it, and we'll see this accelerate at a dramatic level. So quickly, and I didn't realize that Shuva would be sitting in the front row, so I have to say this exactly how I've used this slide before. So we had the first round of KidneyX, and it was for redesigned dialysis, and we had 15 recipients of first round funding, and I can't believe I'm going to do this in front of you. At one end of the spectrum, we had people who've been in this space for a long time and are well known and are more senior, like Shuva. At the other end of the spectrum, we had 3 undergraduates from Stanford, who I think we would all agree most of the crowd, if you want to know who the crowd favorites were, it was the Stanford undergrads, who I think got like 10 job offers after this. But that's the excitement. If we can get people like this, undergrads, excited about this, starting to dedicate their careers to kidney research, to caring for people with kidney diseases, think about the difference that can make. And so I think that's the power of what we're trying to do. So I'll go through 7, 8, and 9 quickly. I think they're important, but they're probably a little less relevant for this discussion. The first is we need to develop strong leaders and mentors as well as embrace diversity and inclusion. And there's a lot happening in this arena. This is not something that used to exist, I think, in the kidney arena in any way sort of from a structural perspective. And these are just 3 sort of parts from ASN's strategic plan around diversity and inclusiveness, around the pipeline of health professional scientists and educators, and then around sort of career advancement. Once people are on this career path, what can we do to support them regardless of the path that they take? The next piece, just circling back to the lack of interest in pursuing careers, particularly as nephrologists, is we need to step back and look at how certification, recertification, and training is organized. If you compare us to cardiology early on, you differentiate and you make a decision about what kind of cardiologist you want to be. I think as we look at the future of medicine, that seems where we're going, where it's much more specialized and reductionist. That's probably our future. And so then there's other models. There's a hospital medicine model. There's a sort of joint accreditation where maybe we work with, say, pulmonary and nephrology. So there's a lot of options here. This is something that we're spending time working with the different sort of regulators as to how we can fix this issue. And then finally, we just fundamentally have to reimagine fellowship training. The interest has been low enough for too long that we just need to do things differently. And there's actually a program called AIR. So I'm calling it AIR Nephrology. I'm gonna trademark that. And so AIR Nephrology is going to basically be an opportunity for a select number of specialty fellowship programs to try very different things. And my hope is that they'll try, I'm afraid to try to go backwards here. Hey, they'll try each of these different models, and hopefully we'll start to have results and they'll be positive. So in closing, and I thought about this from the perspective of those of you with kidney diseases or kidney failure, but I think this is probably applicable to everyone in the room. At this moment in time, we as a broad community need to work together to reassert the value of nephrology. And there's at least 7 things that each of us can do. The first is, starting with the Stockdale paradox, confront the brutal facts, but never lose faith. That just needs to be sort of our working agreement. The second piece is we need to use every opportunity to advocate for yourself and for the kidney community. So the other day I went to finally see the Avengers Endgame, which I'm not sure why that had to be 3 hours long. Although I will say that it was far superior to, I'm blanking on Peggy's example, because hers was DC and this was Marvel. Anyway, so I was going and I went to get water, and the guy said, would you like to leave your change for St. Luke's or for it was a kid's cancer thing? And I said, no, I give all my money to kidney research. And my daughter looked at me like, you just are the biggest idiot I've ever met. But the point is, I was trying to advocate for kidney diseases. The third is that we need to demand that there's one number. I admit that 850 million is probably not perfect, but it's the best we could do at a world level. Let's just reach agreement on what we want to use in the U.S. and all the organizations use that number. It hurts our credibility when we're all coming in with different numbers, and that seems like a relatively low bar that we should be able to cross. The fourth is this issue around lexicon. I think the KDIGO effort's a good first start, but let's step back and look at the words we use from the perspective of the public and not from the perspective of the scientist, because we need to communicate and we need to get our message out there more effectively. I think it's important for everyone to participate in organizations like AAKP or like ASN or any other RPA or any other organization. You have to get involved, and there's a lot of opportunities to do that. In terms of specifically the ASN Alliance for Kidney Health, and I switched from patient-centered to patient-directed, these are the types of things we're trying to do. Again, we're a health professional organization. Our members are physicians and PhD scientists and other health professionals. We are including the patient perspective in education and communications and publications and policy and advocacy, and all we're doing related to workforce. There's a huge patient role in the Kidney Health Initiative, as well as with the NTDS, the AKI Now, and as we launch the DKD effort, we're trying to include a patient perspective. And then finally, with Kidney X, there will be patients as we roll out the sort of governing board. There are patients involved at every step of the way as we went forward with the first set of prizes. And we are in the process of developing the second competition, which is going to be around patient innovation. So we're really excited about that. Then the final point, and then my final slide is, I think it's time for us to unleash our inner pirates. And I've got people's attention now, right? So what I mean by that is, this is my favorite quote. You can tell that Richard and I have very different sources. I'm talking about Marvel, and he's got Margaret Mead. But innovation is a pirate ship that sails into a yacht club. And it's time for us to start acting more like that. So I will stop there. Thank you very much for your time.